All right, team. Let's talk about one of the most classic surgical consults you're ever going to get. You've got a patient on a blood thinner for atrial fibrillation, and they need to go to the OR. So the million-dollar question is, when you stop their main anticoagulant, do you need to bridge them with a temporary one? To bridge or not to bridge? Let's unpack this.
Look, this is the reality. We are walking a perioperative tightrope every single time. On one side, you have the devastating risk of a stroke if a clot forms while they're off their meds. But on the other side, well, that's the surgeon's nightmare, right? A major, uncontrollable bleed in the operating room because you used a bridge. It is a very, very high-stakes balancing act.
So here's what it all comes down to. How do we decide which patient is so unsteady on that tightrope that they actually need a safety net? How do we put a number on that risk instead of just guessing?
Okay, so how do we make this critical call? Well, thankfully, we have an awesome data-driven tool for this exact problem. I want you to think of it as our very own stroke risk meter, something that gives us a clear, actionable number to guide our decision.
And that tool, of course, is the CHA₂DS₂ VASc score. Now, don't let that clunky name throw you off. At its core, it's just a simple scoring system for our AFib patients. The higher the score, the higher their annual risk of having a stroke. It's really that simple. More points equals more danger. It's basically our game show scoreboard for stroke risk.
So let's break down how we actually rack up these points. C is for congestive heart failure, a weak heart. That's 1 point. H for hypertension, you get another point. Now notice the little 2s. Those are the heavy hitters. A2 for age 75 or older gets you 2 points. D for diabetes is 1 point. And here's the other big one. S2 for a prior stroke, TIA, or clot also gets 2 points. V is for vascular disease. Think a past heart attack, clogged pipes in the legs, that kind of thing. That adds 1 point. A for age 65 to 74 gets 1 point. And finally, SC for sex category, being female, adds 1 point. Let's start adding them up.
Okay, so now we have a score. The real question is, what do we do with that number? Well, this is where it gets practical. We can sort pretty much every patient into one of 3 simple risk buckets that tell us exactly what to do.
First up, the green light zone. This is a score of 0, maybe 1. These folks are low risk. And for them, the data is crystal clear. The risk of causing a major bleed by bridging far outweighs any tiny benefit you might get. So we almost never, ever bridge here. We can all just take a deep breath and relax. Now for the yellow light, the intermediate risk zone. This is a score of, say, 1 to 3. And this is where the famous bridge trial totally changed the game for us. What did it show? For most of these patients, bridging with heparin led to a huge increase in major bleeding without actually preventing any more strokes. So the modern, evidence-based answer here is still a confident no bridge.
And finally, we have the red alert. Now we're talking about a super high score. Think 7, 8, or 9. In this zone, the patient's annual stroke risk is so incredibly high that the whole equation flips. Here, the risk of a stroke is just too great, and we have to seriously, seriously consider using that bridging safety net.
But hold on, there's one more layer. I want you to think of these as red flag overlays. These are conditions so high risk that they act like a trump card. They automatically launch the patient into the you need to think about bridging category no matter what their CHA₂DS₂ VASc score is. The big ones? A mechanical mitral valve, a very recent stroke or clot, we're talking less than 3 months, rheumatic heart disease, or a recent VTE. These are absolute game changers. Okay, theory is great, but let's make this real. Let's apply this whole framework to our first case, Mr. Smith. He's your classic no-bridge scenario.
So here's Mr. Smith. He's on warfarin for his AFib, and he needs a lap chole. His risk factors, he's got hypertension, he has diabetes, and he's 70 years old. Let's go ahead and calculate his score.
All right, let's tally it up. We've got 1 point for hypertension. Ding! 1 point for diabetes. Ding! And 1 point for being between 65 and 74. Ding! That gives him a grand total of 3. And a score of 3 puts him right smack in the middle of that intermediate risk yellow light zone.
So what's the game plan for Mr. Smith? It's beautifully simple. We stop his warfarin 5 days before surgery so his INR can come down. And the critical step, we do not start a heparin bridge. We're going to let that medication wash out because we know adding a bridge would just jack up his bleeding risk for almost no benefit. Then, after the surgery, once we're sure he's not bleeding, we restart his warfarin. Easy.
Now, let's flip the script completely. Let's meet Miss Lopez. This is our high-stakes case where we absolutely need that safety net what I like to call the trampoline bridge.
Okay, so Miss Lopez also has AFib. But look at this, her risk factors are just piling up. She's 78, she's had a stroke before, she has hypertension, and she has diabetes. I mean, you can already tell her CHA₂DS₂ VASc score is going to be through the roof.
But that isn't even the most important piece of information here. Here's the kicker, the red flag overlay. She has a mechanical mitral valve. This is the siren going off. This changes everything.
With a mechanical mitral valve, forget the score for a second, her risk of throwing a massive, catastrophic clot if we stop her anticoagulation for 5 days is it's extreme. It is not a risk we can afford to take. The valve trumps the score, and it demands a bridge.
So her plan needs that safety net. We still stop her warfarin 5 days before surgery, but as its effect fades, we start a bridge with a short-acting agent like heparin. I want you to picture this like a trampoline that appears under our tightrope walker. It keeps her protected from a fall. We stop that heparin bridge about 24 hours before the operation to give the surgeon a clear field, and then we get her anticoagulation back on board safely afterwards. That trampoline is what protects her.
So let's boil all of this down to the surgeon's rule of thumb. This is the high-yield summary you need to have locked and loaded for your exams and honestly for rounds every single day. If you remember one thing from this, let it be the mnemonic STREAM. These are your absolute high-yield, gotta-know indications for bridging. S is for a recent stroke. T is for a severe thrombophilia. R is for rheumatic valvular disease. E is for a recent embolism. A is for atrial fibrillation with a really high CHA₂DS₂ VASc score, like 7 or more. And M is for mechanical valves, especially those mitral valves. If your patient has any one of these, you are in the bridging conversation, period.
So the takeaway here is really clear. This isn't about gut feelings or guesswork. It's about systematic risk stratification. So the next time you see a patient with AFib on that pre-op list, what's the very first score you're going to calculate? You know the answer.